So, yes, thank you very much for the introduction. These are my declarations of independence of interest, so that you know who pays me. I'm, as Lawrence said, I'm a partner in the Kingsway Surgery in Swansea. I've been there for 20 years. I was a medical registrar before that, but so I'm a bit older than I should be for a 20-year cert GP. I'm on a practice cluster as the practice representative in the city cluster in Swansea. I am on the exec of the LMC locally, and I've been to LMC Wales meetings and put forward proposals in relation to green events. And I'm also an examiner with the College of GPs. Sorry, you're probably not able to see anything other than my chest at the moment. So, and I've got, I also teach on the exam prep course. So I've got an educational bent, and I've got a company that I do stuff through. So those are all the people who pay me. But I used to joke to an extent that global warming was something that wasn't really going to affect me because it was going to happen at some point in the future. But actually, severe storms have been a problem. And as people have pointed out, there's a heat wave, unprecedented. Actually, this is today's map. No, sorry, that's yesterday's. I haven't updated it. These things that people were predicting might happen by 2040 are actually happening. So we're in the midst of a crisis right now. And it was really seeing the response to the COVID pandemic and how people could respond, and governments could respond when faced with something that was really quite serious, and that they acknowledged it was serious, and then seeing the contrast with how we were dealing with the global warming crisis. That's what made me get involved in trying to deal with global warming. My educational bent meant that I wanted to ask two questions, but I can see there's 100 and odd participants, and I don't think that this is something that I can get you to do in the chat. But it might be something that you want to write down, because it will allow you to figure out where are you on the level of knowledge. And I would have aimed to pitch things specifically to you. That write down something you know about the interaction between healthcare and global warming, and also one thing you want to learn today. Now, that's what I was aiming to do. So I think there's just too many people here to be able to do that. So I'll just move on. I do want you to try and answer this though. Which of these is the worst for the environment? I'll give you some background. I weighed an empty Ventolin canister. It weighed 12 grams, and a full one weighed 29 grams. So I'm talking about 17 grams of drug and propellant. How much global warming does it cause? And I think we need an awareness of these things in order to be able to deal with it. So have a measure of that. By all means, you don't have to stick anything in chat. If you can, that's great. But if you can't, then that's fine. But write down an answer for yourself, because we need an awareness of these things in order to be able to actually adequately do the things that we're trying to do, which is deal with global warming. And maybe you've got an answer for yourself. I hope you have. Actually, there's a big difference in the effect of different inhalers. So because Ventolin Evohaler has got a large volume of propellant in them, and those propellants are greenhouse gases, then that's the equivalent of 28 kilograms of CO2, 28 kilograms of CO2 equivalent in one of those, compared to a Salamol pressurized meter dose inhaler, which is only 10 kilograms of CO2. So same number of doses, same drug delivery mechanism, but a much smaller carbon footprint from using a smaller propellant volume. Compare that with a dry powder inhaler, and you're looking at a much smaller footprint again. And that's why there is a push towards us using dry powder inhaler, soft mist inhalers, like the Respimat devices. There is a potential problem with Respimat, because actually one of the things that I want to be able to do is use one device type for my patient, rather than using multiple different device types, because they require different inhalation techniques. So actually you're likely to get better delivery if you're just using one type of inhaler. And there doesn't seem to be any Respimat inhaled corticosteroid volume. There's something in chat about Ventolin, Acihela has been removed from the All Wales asthma COPD guidelines due to cost. Yeah, okay, that's just there as a demonstration. I've got a feeling that I've seen something that GSK have reduced the cost of that, so it is comparable to other things. But there you are. But actually, there's also, you need an awareness that there are PMDIs that are even more damaging to the environment than the Ventolin. So Flutoform and Symbicort, which are normally prescribed as dry powder inhalers, well, actually, if you use the PMDI versions of those, they've got a 37 kilogram CO2 equivalent dosing. So there's a significantly higher problem again in terms of global warming from them. And let's compare that to 1 day as an inpatient. That is calculated to have an approximately 38 kilograms CO2 equivalent footprint, according to the Centre for Sustainable Healthcare. So, you know, we are talking a significant amount of global warming from these. And let's put that in context. The Ventolin Evohaler, that is the same sort of carbon footprint as a 175-mile drive in a medium-sized car. That'll get you from London to Sheffield, whereas the Acihela is only a 4-mile carbon footprint. So those are the equivalents. One of the things that I actually think is quite useful for me in terms of thinking about things as well is something that came from a book by Mike Berners-Lee, which is actually, what does this mean? Well, if you take a chickpea-sized piece of dollop of petrol and you burn it, that's about 1 gram of CO2 equivalent. If you take a pint of petrol and burn that, that's about 1 kilogram of CO2 equivalent. So, you know, this is the amount of damage that we're doing with these things. So we need to understand the context of it. And I've put this slide in separately because although this comes from NHS England, the stuff in the orange at the very front of it is looking at the primary care aspect of it that's not in the Welsh strategic document from the Carbon Trust. And you will see on the very left-hand side of that slide, no, sorry, the right-hand side of the slide, is pharmaceuticals in the carbon footprint of those in primary care is our biggest contributor. And that includes the inhalers. Inhalers are said to be about 4% of the carbon footprint of the NHS, and that's worked out on volumes of use and the volumes of global of greenhouse gases that are included as propellants, not the pricing of them. I think the other pharmaceuticals probably are pricing. As Steve said, I don't know how they were worked out, but it's on volumes of propellant for the PMDIs. Okay, so what's happening in primary care? Well, those of you who work in primary care will be aware that one of the quality and improvement framework projects that you can do this year is a green inhaler project. The aim is to reduce the carbon footprint of inhaler prescribing by better asthma and COPD care, using dry powder or soft mist inhalers first line where clinically appropriate. And if you use metered dose inhalers, then choose a brand and dosage regimen to minimize the carbon footprint. So use Salamol rather than Ventolin Evohaler because it's got a smaller footprint for the same effect. I've got to be honest, although this is laudable, at 35 points for this compared to a UTI audit, I don't think that this is costed adequately for what we need to achieve, but it's a step forward from what we did have. And then the next thing is the All Wales Asthma Management and Prescribing Guidance and the COPD guidance as well, which have been put out, and I'm sure that Simon Barry will talk about these later. These have been distributed nationally, they're available electronically, and paper versions have been distributed to most, I think probably all practices, multiple copies. This is an early iteration of the map, and you can see that it looks at dry powder and metered dose inhalers separately in each of the stages. The other thing that is on the more more up-to-date versions of it is that there are little green and red footprints on the graph next to the inhaler devices, next to the pictures of them, so that you understand better those with a green, a lower carbon footprint, and those with a red or more damaging carbon footprint. And these guidelines have been disseminated also in the All Wales Medicine Strategy Group guidance on, there's one on asthma, there's one on COPD, and included in the as national prescribing indicators. This document is actually very useful because it talks in more detail about what's happening. Okay, I've got a query I'll deal with afterwards. And so the guidance is actually gives you more information and allows you to implement things better. And largely it's talking about using single inhaler types. If you're going to use a pressurized meter dose inhaler, you should be doing that with a spacer to get better drug delivery. There's a push towards using marked regimens, which avoid over reliance on short-acting bronchodilators, and will allow you to manage people's asthma better, probably with a lower inhaler dosing. And as I said, they've been embedded into the prescribing indicators. So if you look at the support that's there for the national prescribing indicators, it's suggesting that you, again, consider a dry powder inhaler when you give a new inhaler first off, and doing respiratory reviews, that you think about low carbon alternatives when patients are currently using pressurized meter dose inhalers. If patients are using several classes of inhalers and you spot that they've got poor technique with one device, then try and teach the dry powder inhaler better and try and use that on a priority. And I would probably go further than that. And I think that's something that Simon Barry would be saying as well, is, well, just stick with one device type, because then it's easier for people to use it rather than having to use multiple different techniques. And then only change things when it's safe and you can see that they're able to use the new device. Okay, all great. The problem that we've got is that actually the trend of the prescribing dry powder inhalers and soft mist inhalers is going the wrong way in pretty much every health board in Wales, apart from Hywel and is it Cardiff and Vale, where it's roughly the same. It has been getting worse, but actually we're getting worse at prescribing the lower carbon footprint inhalers. So despite the national prescribing indicators, this is not being effective. Okay, this is only till this time last year, but this is what's in the data that we're seeing. So I suspect that despite these pushes, we need to have stronger incentives for people to be doing the right thing. You know, it's a lot of work to be doing this. And then the other issue is around disposing of inhalers correctly. They're, on average, when inhalers are disposed of, according to a study that came out of Nottingham, the School of Pharmacy up there, most of them have still got 50% of the doses still in them. These devices don't have dose counters on them, which almost I think every dry powder inhaler I've seen has got. So people throw them away when they're still half empty, so that's twice the cost, and actually all the gases they're being thrown into landfill, so the gases are just being released to the atmosphere without any clinical benefit at all. Steve Hall talked about there being some recycling schemes, and I think someone's going to speak later on about one that's running in Swansea Bay, a recycling project there. Basically, the gases that they use are also used as refrigerants, and if you disposed of a fridge, they would have to be disposed of safely. We haven't got that requirement in there for inhalers. But if you take your inhaler back to a community pharmacy, it can be collected and incinerated, which is actually less damaging. And the project that I think someone will talk about later is talking about how we can actually collect and recycle those canisters. We've also got an issue talking about circular economies of the fact that the plastics in the inhalers are not currently recyclable, and we need to be thinking about how we can deal with the devices in order for them to be processed safely and appropriately, and perhaps reused. One of the great things about the Respimat is that actually you've got one inhaler, you can reuse it 6 times by putting by renewing the canisters in them, and that cuts down on the carbon footprint of them. Doesn't perhaps bring it down quite as much as some of the other dry powder inhalers, but again, we are going to have to be looking at how we can collect these things, because once we can collect them, we can do something with them potentially. Okay, so what else can we do? Well, someone else has talked about Andy's project of actually stop smoking. Well, yeah, burning a cigarette has got a carbon footprint of its own, and there's an environmental impact of the growing the tobacco. But actually, if you've got asthma or COPD and you carry on smoking, then you're going to have worse control. You need higher inhaled corticosteroid doses. You're more likely to get exacerbations, is my gut feeling. So helping people to stop smoking is really important. So getting that the community pharmacies back into the offering the stop smoking services will be really, really important. I think that the one next door to me hasn't actually restarted that yet, but this has also got a benefit for decarbonisation with better asthma control. Vaccination against respiratory diseases, flu and probably COVID, are massively important. They're perhaps way more important for people with COPD than using SABAs. So actually, us delivering on this is going to be massively important again in terms of keeping down the SABA use, and also keeping people out of hospital, which, as I said earlier, has got a big carbon footprint. And then also treating hay fever, rhinitis more effectively. That's a non-propellant driven device. And if people have poor asthma control and have rhinitis, then treating the rhinitis will often help their asthma control. Then the other thing that is happening is quality improvement projects. So the idea of SUSQI, sustainable quality improvement, which if you go on the website for the Centre for Sustainable Healthcare based in Oxford, they talk about this, and there are a variety of projects that you can sign up. They will teach you how to do these things. Is thinking more widely about the value that we're getting out of quality improvement projects, looking at the outcomes for not just the patient but also the population. And then they use this idea of a triple bottom line of the costs, the impacts being the environmental, social and the financial impacts, not just the financial impacts. So broadening that definition of what the impacts are of things. So one thing I do want you to think about today and write down is, what will you do differently after today? Because actually, this isn't just about telling you about stuff, it's about you all taking something on and actually committing to some sort of change. So I would like you all to write down, what will you do differently after today? One thing. The thing that I felt was the biggest change that I could make quite straightforwardly was to switch from Ventolin Evo Halo, which had become which had somehow become the default in my practice through the prescribing patterns that we'd been pushed to use branded products, to move that to Salamol. That more than halved the carbon footprint of my prescribing, inhaler prescribing pretty quickly. There's been a very, very small pushback from patients, but not very much at all. Effectively using the same device, the same medicine, you're using it in the same way, but you're just using a much, much smaller volume of it. And this had a big impact for me. It's not replacing the fact that we need to switch to dry powder inhalers and we need better asthma care, but that takes time, whereas this switch is something that you can effectively do straight away. Okay. The other thing that I would encourage any of you to do, if you're interested in trying to decarbonise primary care, is to get in touch with us at the Greener Practice Wales email. Come join us, get our email letters around, come join some of our meetings, because we want to link up people in primary care who are interested in dealing with this. The hospital system, the health board systems, I think every health board now has a green group. I was involved in setting up the one in Swansea Bay, but the vast majority of people in it are hospitalists. And actually, the problems that we're dealing with in general practice are different from what the hospitals are. Every department has got something that they've got to deal with there. I think our big problems are inhalers, the scope 3 emissions from other pharmaceuticals that we're going to have to deal with, and hopefully industry is going to be a big part of the solution in terms of the delivery of pharmaceuticals becoming net zero, because I'm not certain how I'm going to deal with that otherwise, but the deprescribing is going to be useful as well.